All right, everybody. So sorry for the difficult technological issues I experienced, but I went ahead and working on the recordings for our webinar series. So for those of you who don't know me, my name is Kelsey, and we're going to be talking a little bit about two different topics today. So we're going to be talking about anesthesia for you guys as you prepare for your VTNE, which you guys are preparing for. And so we'll kind of jump into that. But before I really go deep into that scenario, I do want to let you guys know of some of the resources you have access to. So if you go to the AAVSB website, which you guys should already be familiar with because this is where you go to apply to take your VTNE, but there's a lot of resources on here. So when you go to exam services and you scroll down to your VTNE section here, this will tell you all the updated things you need to know when the windows are open and closed. But if you scroll down further after the application processes, you can actually go to study for the exam. So this is really helpful because if you're able, you should definitely look into purchasing the practice test. The practice test gives you an idea of how the software works, as well as how the questions are worded. And so this is something really useful because you can actually see where you need to study at. And if you're not able, definitely maybe see if your work would be willing to sponsor purchasing these tests for you, because this is going to be a vital tool. I also do want to let you guys know the domain task list. So this task list is super helpful in the regards to it shows you what categories are going to be on the VTNE. And this year they added a 10th category. So that's the communication and veterinary professional support services. And here it tells you how many items that go with that domain as well as that percentage. So you can see anesthesia is a pretty hefty one. And so that's about 13% of the test. And you'll see that the test has 150 questions. So when you do sit for your board, you actually will be testing 170 questions, but the 20 question difference is there is going to be those pilot questions. So that means those questions do not count to your final score. Unfortunately, you don't know which ones are pilot questions, so you do need to take every question seriously. I also do want to be very transparent for you guys because a lot of students think they just need to get 115 questions right to pass, when actually this comprehension test is a weighted test, meaning every question has a different percentage weight to it. So one question might actually be worth more points than the other. So keep that in mind when you're studying. And again, I highly recommend you print this out because this really breaks down all the objectives per category. So you can really check in with yourself to make sure you understand those aspects. So definitely look at the AAVSB website. So we'll go ahead and jump into our presentation here. And we're going to be talking about anesthesia. And so unfortunately, we can't cover every nook and cranny for you guys, but we're going to hit the basics. And this will kind of be a good review for you guys in regards to what you maybe need to review a little bit more or something that you didn't quite have a handle on. So we're going to discuss that. So when we talk about anesthesia, there are different types of anesthesia for us. And so that is when we, as technicians, are going to be very valuable because we play that role in helping make sure these anesthetic procedures go smooth. And when we talk about anesthesia, it's not only intraoperative that we are working on this. When we talk about anesthesia, we do have the ability to do pre-op care and post-op care. So this is a start to finish goal. And so as technicians, we're going to understand our patient's needs, which then will determine our drug protocol, which will determine what we kind of go forward with which anesthesia we're going to go with, because every patient's going to present at the clinic for different needs, whether it's a general practice type surgery, just a spay and neuter, or something a little more invasive like a limb amputation, or even cardiac surgery, or something that's traumatic, to even just a wound repair. Anesthesia is involved in all aspects of that. Let's see here. Here we go. Hello. There it is. So the first thing when people hear anesthesia, it's going to be general anesthesia. And so that is when the patient is fully unconscious. We really manipulated the CNS system and we're blocking all the channels in the body there. We are telling the patient, you cannot move, you are not awake. And so the patients are fully intubated They have multiple monitors hooked up to them because we want to ensure that all their organ systems are functioning correctly. And so with general anesthesia, we're taking away their ability to move any muscles in that brain to communicate. We don't want our patient awake. We don't want them aware, especially if it's something invasive like this for like a colic surgery. We don't want this patient jumping off the table, having any pain responses. And so with our general anesthesia, we're also stacking analgesia, which these kind of go hand in hand because we don't want to have our patient in pain and then have them waking up on the table. Another thing that you guys have experienced being at school is we do our local anesthetics. So this is when we use that analgesic effect, especially for our line blocks for spays or a testicular block for neuters, or if your general practice does offer dentals and extractions, this is where they will be able to do a dental block. And so we're going into a specific region area and we're trying to make sure that we're blocking those pain receptors so we don't have our patient having any pain responses. This is also a good gold standard care because, again, we don't want our patients feeling pain and continuing that triggering response. When we talk about local anesthetics, the drugs that we're using is going to be actually lidocaine or bupivacaine. Both drugs do the same exact thing. It's just going to come down to what your clinic has available or who does what purchasing. We also have something called regional anesthesia. So regional anesthesia is very similar to the local, but as in the name, regional is a bigger area. So we're still using the same drugs, and patients are either already pre-meted for this or they're already in full general anesthesia when they're intubated and on gas. And so this is to help again with that analgesic effect where we're blocking nerves on a bigger area so we can move forward. So this is really helpful for any major trauma cases, or something that's really common is if a leg amputation is occurring, like a hind limb, we can go ahead and give that epidural. So this will kind of come more on what is your doctor's comfort level on administering this, but it definitely is something that should be practiced more when we talk about more invasive anesthesia. So still using lidocaine and bupivacaine and just remembering that this is on a larger spectrum. One thing when we talk about our anesthesia is a pre-med protocol. And I've been a part of practices who don't utilize this type of protocol at all. And looking back, that wasn't ideal having to wrestle patients for a catheter, or a patient is really anxious and not being very compliant for a lot of things and required a lot more hands-on. And so it really stresses the patient out, and we're really defeating the purpose of making them comfortable and having things go smooth because now we have triggered their stress responses, their heart rate is elevated, and that's not ideal when we're trying to keep them calm and have things go more smooth. So when we talk about pre-med protocols are really helpful in the sense when we're preparing for anything as much as a quick sedated x-ray exam because the patient is fractious, or when we're doing a spay to even doing more diagnostic type surgeries like a rhinoscopy, dentals. Pre-med is very useful in the sense of getting our patient to be less stressed and to move into our procedures more smoothly. The thing we talk about pre-meds is the key word is multimodal. So multimodal anesthesia or balanced anesthesia is how we use multiple drugs at reduced doses to get our desired effect. So this is more ideal when we're able to stack different types of drugs that work together to give us that desired effect versus doing a large dose of one main drug and then we kind of tap out of our other resources. So really using different types of alpha 2 agonists or an opioid together to give a more sedated approach to our patient is going to help with that pre-op care. And if we're not going under general anesthesia, a sedation pre-med protocol is really helpful for patients who, again, might need more things done, but they're stressed out. So if they do need sedated radiographs or they come in for a broken toenail, this is going to be really helpful. We also have the ability when we use pre-med protocols is the drug type, which will limit the amount of effects we see on our other systems. Because when we talk about drugs as a whole, we are affecting our cardiovascular system mostly and even our respiratory system. And then these drugs will have harsh effects with our kidneys and our liver because that's how drugs are metabolized. So if we have a compromised pet who has kidney disease, then we can adjust our pre-med protocol to help make things more smooth. And we'll be able to not harm that patient as much. The other thing when we talk about our anesthesia is that keyword again, which is analgesia. So our analgesia is that ability to have that pain control. And so because we're putting other drugs in these protocols, we're able to help produce a gold standard because those drugs check off a multiple checklist where they provide anesthesia, analgesia, and they can continue to help keep the patient comfortable. That is our goal with these multiple checklist type drugs. So now we kind of talked about the different steps of anesthesia and different ways we can kind of go about it. But now we need to really talk about our drugs. And so anesthesia does require our knowledge of our pharmaceutical history and understanding how drugs work, their brand name, their generic name, their side effects. And the biggest thing is if your patient is compromised, how is this drug going to affect them? That is an essential thing because as technicians, we handle the drugs the most, but our doctors are the ones who are going to make the protocol call on which drug to use and what dose. But you have to calculate it. And then if you realize that your patient is having some negative side effects to a drug, what drug are you going to use to fix that problem? So our first category is going to be our phenothiazines. So phenothiazines are what we know as acepromazine. So there's only one drug to know in this category. And ACE is actually considered more of a tranquilizer type drug. And so this is used with, again with our difficult handle patients, but a lot of things can go awry when we talk about ACE. So ACE actually, because it's a tranquilizer, we do see long lasting effects even at a low dose. So our patient will still be super lethargic and not moving and not aware of their surroundings for 6 to 8 hours on the low dose and even up to 24 hours. And so this might not be ideal if we do have a compromised patient because we want them to recover smoothly and be able to be responsive to us. The other thing with acepromazine is it doesn't have any analgesic effects. So we're not going to have any pain control while we're trying to sedate the patient. So if that's not our goal, this drug isn't going to be what we want to use. When we talk about our different types of patients and if they're compromised or not, what systemic diseases do they have, is with this drug, this is not going to be ideal for our cardiac compromised patients because this can already drop our blood pressure as ACE actually vasodilates the blood vessels, and we can also see a reduction in temperature. So our older dogs aren't going to benefit from this either. And then knowing what breeds of dogs might have negative side effects. So a common dog and owners you'll hear that have border collies will talk to you about NDR1. And so those types of dogs are sensitive to certain heartworm preventions, and so they also can be sensitive to acepromazine. So NDR1 patients are our border collies. And then last, when we talk about ACE, ACE isn't reversible. So this drug isn't going to typically be a top pick for a veterinarian. It might be something depending on if our patient is truly aggressive and we're just trying to do something very basic to them, they might go ahead and choose this. But again, this doesn't have any analgesic effects and it's not reversible. And we can see those prolonged sedation type effects on our patient. Our other category of drug is going to be our alpha 2 agonist. So this drug category is a very versatile drug because this drug is able to not only provide sedation, but it also provides analgesia and it's reversible. When we're in the clinic, this drug isn't considered a controlled substance, so it's easy to access if you ever need it when you're assisting a veterinarian. The two types of drugs that we use that are in this category are going to be dexmedetomidine. And so make sure you understand, I know there's a lot of different type of dex drugs out there. So make sure when you're referencing any drug for sedation protocols, it's going to be dexmedetomidine. And then we also have our xylazine. Xylazine, I see a lot more in our equine patients, but in small animal medicine, it is available, but your most common one's going to be dexmedetomidine. Now, since we talked about, hey, these drugs are reversible, you really need to know what goes with which one. So they each have their own reversal agent. So dexmedetomidine is actually reversed with antecedent, and xylazine is reversed with yohimbine. And so the way I remember that, a little fun little identifier, is dex and an antecedent are at the beginning of the alphabet because of A and D. Whereas xylazine and yohimbine are at the end of the alphabet. So that really helps you make sure you're grabbing the right reversal agent when a doctor gives you directions to reverse whichever drug. The thing we do see when we talk about alpha 2 agonists is if our patient is cardiac compromised, this isn't going to be super helpful. Or if the patient is older or is diabetic, we're going to see some side effects, which the most common ones we'll see are going to be profound hypertension and bradycardic events, and we'll see a lot of reduced cardiac output. So when we talk about our drugs and we're in our anesthesia or in our surgery room and we start to see a patient having bradycardia, so typically a heart rate around 60 or less, you'd want to communicate that with the doctor. And so as a technician, you would think, hey, we're having bradycardia. I should go ahead and reach for an anticholinergic. So that would be our atropine or our glycopyrrolate. But in reality, when we're working with DEX, we don't want to do that because if we do try to give an anticholinergic, we're actually going to increase the cardiac workload on the heart. And we're going to start seeing more arrhythmias and we can cause some other organ damages if this goes on too long. And so typically when we start seeing events like this, how we want to communicate with our doctor is letting them know we see this and they're going to want to ask you to go ahead and reverse. But you can also, with the reversals, that's nice because you can reverse at a quarter or half dose. So the doctor might be like, hey, let's go ahead and give half of the antecedent dose. And so typically you should have an emergency drug sheet available that has these calculations available for you, or they will tell you how many megs per kg type situation, and you can draw that up. When we do it at a quarter or a half dose, it's nice because we can still get the effects of having the alpha 2 agonist on board without the severe side effects. And so we won't be seeing those bradycardic events, or we shouldn't. So when we're dealing with DEX, it's ideal to reverse it, not give an anticholinergic. Our other category drug, which you guys should be familiar with, is our benzodiazepines. So the two most common ones are going to be diazepam and midazolam. And so these guys help with sedation. So they really give us that muscle relaxation and they really help us with immobilizing the pet. The nice thing is if you do have a patient with a seizure history, we want to make sure they're safe. And so benzos are very safe with patients with that because going to the clinic can be very stressful. And so these patients can have stress induced seizures. So this will be one to have on board. The nice thing is these drugs can actually be a part of a pre-med protocol or with a induction protocol. They're never really used on their own for these types of practices. So if we're wanting to sedate a patient fully, we're not going to just reach for a benzo. These are a part of a multimodal drug effect. So this is where we're doing that balanced anesthesia. When we talk about the different types, so it might come down to what does your clinic purchase, but what's going to be more versatile. So diazepam, its solubility isn't as strong as midazolam. So typically diazepam is only given IV to see the effects readily, whereas we're not seeing the effects we want when we give it IM or sub-Q. So that's why a lot of veterinarians will just go ahead and carry midazolam because it's safe in all routes, and we do see the desired effects both IV, IM, and sub-Q. And the best thing when I use this drug, it's nice because it helps a part of that pre-med protocol, and we're already getting those desired effects to make the patient more compliant. Now we have our opioids. So here in veterinary medicine, we do use opioids just like with people. And so these are controlled substances. And depending on what your clinic is comfortable having, or if they have a veterinarian that has their DEA license, will determine if you have these on board. With opioids, it's nice because it does check a lot of those boxes where it does give us that analgesic effect and it is a part of a pre-med protocol and we can use it post-op as well. And we don't see a lot of negative side effects. We do see maybe some respiratory depression, but that's at extremely high doses. But when we're just in the clinic and after we administer an opioid, we're not going to see those negative side effects of any arrhythmias or respiratory depression or even excitability when we give this drug. So what we use in veterinary medicine, we have buprenorphine, butorphanol, fentanyl, hydromorphone, and morphine. And so the most common ones I've used in practice is actually butorphanol or Torb and buprenorphine. My clinics I've worked at never really carry fentanyl, but if you're in an ER situation or if you work at like a surgical specialty center, fentanyl is going to be available whether it's on a patch or injectable. When we break down our opioids, they actually go into further classes. So we have something called a full mu opioid and a partial mu opioid. And so this is just how they affect the brain differently. So with our full mu agonist, this is how we're able to um, definitely affect the brain on those mu receptors fully. And so this is really helpful from anything from a mild procedure to severe. And so the drugs that fall into a full meal category is going to be our hydromorphone, morphine, and fentanyl. And then our partial agonist, this is where we have our buprenorphine. And so this is more for our mild to moderate pain control. But the thing is, when we work with buprenorphine, we tend to not see fast effects right away. So if we want instant pain control, it's not going to kick in for at least 15 minutes, even if it's given IV. And so when that is as long as it is IV, our IM injections are even longer at least 40 minutes till we start seeing the comfort level to our patients. We don't really give this injection sub-Q, but with some of our pharmacies and our compounding pharmacies, we do have the ability to have it in a transmucosal route for our kidney patients. So when we talk about versatility, buprenorphine is very specific in regards to it doesn't readily act and it's only given one way the best, and that's typically IV. We also have a drug that's kind of unique. So our butorphanol, or that drug, is actually considered an agonist or an antagonist. So this guy actually can provide some sedation to mild procedures, and you can readily give this, and it won't last as long in the system. It's very short acting. So you can use this a part of your pre-med protocol. And then if you notice your patient is becoming very painful responsive to surgery and you're seeing signs of tachycardia, we can give an additional butorphanol dose. The thing is, how it kind of classifies as an agonist and an antagonist is because it can actually reverse only full meal opioids. So if we don't have naloxone available, which is the reversal for our opioids, we can use Torb to reverse our full meal opioids. So keep that in mind on how versatile that drug is. It's considered an agonist and an antagonist when we talk about our opioids. So our other category of drug is our cyclohexamines. So the most common one you're going to work with is going to be ketamine. So a lot of doctors will use this as a pre-med and an induction agent, but it's not used on its own. So it's usually given with a benzo. But the one thing is with this type of injectable, it does give more of a dissociative effect. And a lot of doctors don't like to use it depending on if our patient is compromised or not, because actually ketamine will increase the heart rate. We will see increased jaw tone. We won't see a lot of blinking going on. We also will see some interesting breathing because our breathing patterns will not be consistent. We'll see a lot of short, rapid breaths, holding their breaths, short, holding their breath, holding their breath. It'll just kind of bounce back and forth. So it can really make it difficult if we do have a respiratory compromised pet and we're giving them a drug like this. The thing too with ketamine is it can be given IV or IM, but again, it's not ideal for patients with pre-existing diseases because of the ability of seeing cardiac arrhythmias. And it is given either IV or IM. So ketamine is available in your clinic, but because of the negative side effects, a lot of people don't really choose it, and that's okay. We also have a drug in our this category is called tilazol. So you need to know this is actually a combination drug that's made from tiltiamine and zolazepam, which is another type of benzo. And so this is actually able to again be used as a part of a pre-med protocol or an induction agent. And it's nice to use because you can use this on aggressive patients to give them a more sedative approach. And we don't see as many side effects like ketamine. And this drug's a little more versatile where we can give it IV, IM, or sub-Q. It just goes back to if your practice has it or not, but these are the two type of drugs that you need to know that fall into that category. So we kind of briefly talked about this is our anticholinergics. So atropine or glycopyrrolate are the two most known in this category. And an anticholinergic, what it does is it helps with any bradycardic events. Now, really old school ways would be a lot of people would give this as a pre-med protocol to help prevent bradycardic events, but that's kind of becoming more controversial because we don't want to give a drug a dog doesn't necessarily need. When we talk about which one's better, a lot of people I've worked with prefer atropine just because it has a quicker onset and doesn't last as long, whereas glycopyrrolate does have a slower onset and tends to last a little longer. Both drugs can be given in either um, route. So we have our IV, IM, and our sub-Q, and it just depends on what your doctors are wanting to give. But this type of drug is to help correct any bradycardic event that you might be seeing. So now that we kind of talked about our pre-meds and our injectables when we're getting ready to go for anesthesia, now we have our different types of inductions. So there's three popular ones, but the most common you probably have all handled the most is going to be our propofol, which this guy is very easygoing on a lot of our patients. But the biggest thing when we talk about propofol is we can see respiratory depression pretty rapidly when we give it, and we can see some hypotension. So this is why we give it very slow. We want to make sure we do have our patient pre-oxygenating when we're prepping them for this. And the one thing is when we talk about propofol and its versatility is it's actually not very helpful in the forms of an analgesic, and it's not a part of any pre-med protocol. Um, but this is what a lot of people will use because it is short acting. So we can give it and we can go ahead and start our procedure. We also have something called Alfax or Alfaxalone. So this one is actually a little more versatile in the sense where it provides more of a muscle relaxation because it's inhibiting the GABA receptors in the brain. And alfaxalone can actually be a part of a pre-med protocol. And it can actually also be given IM or IV and sub-Q. It just depends on what you're doing with it. So when we talk about pre-med protocol, this is where we give it IM, and we can actually see effects kick in pretty quick within 5 to 10 minutes. And our IV induction, we can see pretty rapidly as well. We do want to be just a little careful because we can still see some apnea occur just as a potential side effect. But this drug is a bit more useful in regards to our pre-med protocol and our induction, whereas propofol isn't used as a pre-med protocol, it's strictly for induction. Another one which you might not have seen a lot of is edetomidate. So edetomidate is very short acting, and this will be used actually on our patient who might have severe heart disease. And so we will reach for this if they have any issues with blood pressure or arrhythmic events that occur, because this one isn't going to affect the cardiac output, whereas the others can. And so this is really helpful with patients who are diagnosed with any cardiac diseases. So now we'll kind of roll into when we talk about anesthesia techniques and monitoring. So as a technician, this is our crucial role because we want to make sure that we are understanding the vitals and what they mean and how we interpret them. Is our patient really light? Are they waking up? Are they being responsive to pain? How do we correct that? And we want to make sure we're also still relying on that multimodal anesthesia. We have our maintenance anesthesia, and just bridging all that together is going to help us perform better anesthesia for our patient because we want to implement a med protocol. We want to get all of our vitals ahead of time and making sure we're choosing the right drugs when we're giving the pre-med protocol and our induction. But now we want to talk about how do we keep our patient under, and that is where we come in as technicians because the doctor's job is to be scrubbing sterilely, to be in a difficult procedure where it might be a full abdominal type procedure or invasive procedure. And so they are focusing on that. And that's where we communicate as technicians on where our patient is at. So our maintenance anesthesia, this is our gas. So this is how we continue to keep our patient asleep because our injectables only last for so long. So our injectables get us going in the sense of we're ready for anesthesia. And so maintenance anesthesia is how we keep them under. And so this is where we involve our inhalant drugs. So this is where we have iso or SIBO. Both still work the same, kind of like when we talked about propofol and Alfax. It just kind of depends on what your clinic wants to afford, what type of anesthesia machine you carry, because not all anesthesia machines can use ISO and SIBO interchangeably. And they are dependent on also their concentration operates a little bit different. Our CVOC is at a higher concentration, so we don't operate on the gas dial as high. So we're typically anywhere between a 1.75 and 2.5, whereas our ISO is at a lower concentration. So we're going to have to be operating maybe at a 2.5 to 3. And so it just kind of depends on what your clinic carries. The thing we can see with inhalants is we can have effect in seeing in hypotension, but the nice thing is we can see change and adjust things accordingly. So if our patient's really light, we can go ahead and turn them up, give them a couple breaths. If they're really deep and we're getting close to wanting to wake up, we can go ahead and reduce that nice and easy. We don't have a lot of effects on the cardiac system, which is very nice, and we're very minimally metabolized by the liver. So when we were talking about our drugs earlier, this is where we went into like, hey, we can be affecting the kidney and liver extremely. So that's what's nice when we talk about our maintenance anesthesia. And so this is how we can kind of bump the patient up and down lightly before we do any major protocols like redosing any injectables. We could do a lot of starting to correct any anesthetic issues at our gas. So when we now have our patient ready to go, and this is where we need to know the different types of anesthetic circuits we have available because is our patient really big or are they really small? And so if we have a really small patient, and you'll find some of these numbers are a bit subjective. Some places go 10 kgs or less, 10 pounds or less, 7 pounds or less. It all just depends. But you need to understand typically our smaller dogs like Chihuahuas or even our cats. And if we even have a 20-pound cat, they still get a non-rebreather because their lung space did not change. Their trachea size did not change when they got fat. So our non-rebreather is also known as a Bain circuit. So this is how this circuit delivers oxygen with less resistance. And so the CO2 is actually removed through the scavenging system. And so our patients often have to have a higher oxygen rate in order to remove that CO2. And so oftentimes too, we'll see our patients are getting colder a lot easier. And so that's not uncommon to see on a non-rebreather. We also want to ensure if our patient is at the appropriate oxygen rate, because if it's too low, we can actually cause them to rebreathe, and that will cause respiratory acidosis, which is not ideal. When we talk about comparing what does the non-rebreather and the rebreather system offer, because at clinics, you will be disconnecting certain hoses and connecting ports on the machine to create a non-rebreather or a rebreather. So when we talk about what we're bypassing when we put together a non-rebreather circuit, we're actually bypassing the CO2 canister and the unidirectional valves as well as the pressure manometer. So when we are using a rebreather, we are definitely using those parts of the anesthesia machine. So you definitely need to know what's included in a non-rebreather and a rebreather. Our rebreather is what we call a circle system. So this is where we recycle that CO2 through the soda line. And so this is where we're able to actually operate on a lower oxygen rate due to the removal of the exhaled gases through the circuit itself. And so these are our bigger dogs. So typically in the research, when you look in your book, it'll say 10 kgs or greater, but it'll kind of come down to your clinic protocol and what you guys feel comfortable doing. We also want to talk about what do we monitor. So a lot of places I've worked did bare minimum and other places did every step possible. So when we talk about monitoring, we're not only going to just monitor our heart rate and our respiratory rate, but we're going to talk about our mucous membranes, our capillary refill time, our pulse, our ECG, where are the eyes positioned at. We want to make sure IV catheter is patent. Where's our temperature, our SpO2, our blood pressure, our oxygen rate. This is all vital to how we monitor our patient. So if we have a patient that's too light, they will definitely be more receptive to pain. But if we have a patient who's too deep, they'll be slow to recover and we can actually give them an anesthetic overdose. So what we need to know is how we continuously monitor our patient. That's what's going to give us our best results in regards to how our patients are doing. So the equipment you're often going to be using is going to be our capno meters, our pulse ox, ECG. That's going to give us real time and function, and that's going to be our main use of a lot of things that we have access to in our surgery room. My first clinic, I never touched the ECG machine. Didn't even know how to clip it on. We didn't have one. We never used a blood pressure machine. All we did was a SpO2 and a manual heart rate and respiratory rate. And that's not ideal medicine in the sense of gold standard. It gets by, but to give us the best standard possible, we want to go all out with our monitoring devices to be able to interpret where our patient is at anesthetically. So our vital parameters are going to be a little subjective in regards to what you find in your book and online at valuable resources. But when we talk about under anesthesia, we can see heart rates between 60 and 150 for dogs and 100 to 220. Our size and type of our patient is going to vary. A dog that's a little more athletic, we might see a little bit more consistently elevated heart rate. They might be a little more lean, have more muscle tone like a greyhound. Whereas maybe our more short, stocky breeds, like a Frenchie or a Bulldog, we might see a little bit of a less heart rate. Our tiny Chihuahuas will have a rapid heart rate, or our puppies. So to keep that in mind, but you need to know what's considered low and high. When we take our heart rate, we always want to make sure we auscultate because we don't want to always rely on ECG. So there could be some artifact going on that, or it could be double counting, like in our cat patients. We can see that a lot where the ECG is actually reading like 350 beats per minute, and that's not the case. So you want to definitely use your stethoscope, your ECG machine, and if you have access to esophageal stethoscope, that's great because you can definitely take into account your patient's heart rate and your respiratory rate, which those can again kind of vary under anesthesia. We can see anywhere between 12 and 20 for our dogs, and we can see something between 8 and 18 for our cats. It also depends on what drugs we're using. So keeping that in mind, roughly your ranges is going to be super helpful. So our cardiac monitoring, so we did talk about our ECGs, and so our ECG is really going to help us identify any arrhythmias that occur. So we can see a lot of sinus tachycardia, bradycardia, AV block, and even something called ventricular arrhythmias or ventricular premature complexes. So there's a lot of different ones you can see. So one that I see a lot is going to be VPCs. These can also be breed specific, like our boxers, or any dog that already has a cardiogenic disease. And so we can also see this due to drugs we've used within our pre-med protocol and our anesthesia protocol. You could be dealing with an emergency situation like a GDV dog or a dog that's in shock. So we can definitely see these on our ECG, and we can even sometimes hear them through our Doppler. When we see these, there's a couple things that the doctor can recommend. They can definitely do a lidocaine injection to break it up, especially if we're seeing them in couplets or triplets or more frequently. So we want to break that arrhythmia. If the dog has these chronically, this is where they'll want to work with a cardiologist in regards to getting on a type of drug like mexiletine or sotalol to help control the rhythm. We also have second degree AV block that can also be due to cardiogenic diseases or, again, the drugs we used. So when we talked about dexmedetomidine earlier, we can see second degree AV block during those times, or even first degree. When we break down our ECGs, the biggest thing, I know it's going to be overwhelming when you guys look at all the different ECGs that you can see. And the thing that will help kind of help you when we talk about arrhythmias is knowing sinus bradycardia and sinus tachycardia. So typically anything less than 60 in dogs is considered bradycardic, and anything less than 90 in cats is considered bradycardic. And we don't want these events to happen too long because we can lead to hypotension, and we can start inhibiting the kidney function if they're in sinus bradycardia for too long. So this could be due to the drugs we use in our protocol. They could be super hypothermic, and also maybe our gas is just way too high for our patient. Maybe we didn't reduce it back down nicely when they were starting to wake up. So that's something to keep in mind when we start to see these issues on the ECG. We also have something called sinus tachycardia. So anything above 160 in dogs under anesthesia, and then anything greater than 240 in cats. We can see low blood pressure, and we can see low CO2 during these events. And so this could be due to hypercapnia, or we can be very painful, and that's what's triggering it. A lot of times in my experiences, we'll see sinus tach when we're getting really painful. So this is where we can bring in our pre-med protocol drugs or redose them with a pain med like our butorphanol, or we can turn them on gas very temporarily. Just kind of depends what your doctor feels comfortable with. But knowing that tachycardic means high heart rate and bradycardic means low is going to be very important when you're kind of reviewing your terminology. So something that's really useful that I enjoy reviewing is our capnograph. So this is how we are able to measure our patient's CO2, so with their exhaled breath. And so this is typically attached at the end of their ET tube. And when we're looking at this is when we refer to our waveforms. And so a normal EtCO2, you want to see anywhere between 35 and 45 millimeters of mercury in dogs and about 28 to 32 in cats. So here on our left-hand side here, we see our normal capnograph. Nice, even, inspired, expired breaths. We hit that baseline of 40 relatively easily. And so that's when we know our patient is doing very well when we talk about our anesthetic intervals. So when we see issues with our patients, our job as a technician is to troubleshoot that. And so that's when we can see some issues. So when we have low EtCO2, and so we are seeing less than 35 35 millimeters of mercury. That means we are seeing hypocapnia in our patient. So that's right here on the right-hand side. Even though we see hypo, meaning less, we're actually hyperventilating. So these are going to be short, even thinner than this, and back to back to back to back. They're going to be having increased respiratory rates of 50, 60, even 70 breaths per minute. So this could be occurring for a couple of things. We could be because our ISO is way too low, and we could be hypotensive. And we can also be seeing this due to dead space. So a lot of times when we intubate, we might be having too much excess. We might have over intubated and we might have gone too far down the bronchi. And so we're only able to affect one lung with our gas inhalants. And so that's where we need to do some troubleshooting. When we start to see high EtCO2, so hypercapnia, we're actually hypoventilating. So our ISO is too high. Maybe our patient is really obese, or our positioning, because maybe we're doing an interesting procedure or the patient has to be positioned a certain way. We can see them to have these big, deep breaths that surpass that 40 baseline there. And so this is where we can check, is our patients shivering? Is their gas way too high? Did we troubleshoot our machine before we connected? Is there a leak somewhere? Or is our soda line really exhausted? So that's something when we notice if it's purple. And so that's how you kind of need to understand what you're seeing and how we come about this. So typically our first go-to is, how's our gas on our patient? Can we turn them down? Can we turn them up? How's our blood pressure? Because if our blood pressure is really low, we don't want to keep turning our patient up on anesthesia. So another monitoring device, we have our pulse ox, which these guys are helpful and not helpful. They definitely can read the oxygen in the room, but they can be helpful with our like brachycephalic patients. So this is how we measure the hemoglobin that's saturated with oxygen. That's how we get our SpO2. So typically we want to see anywhere between 95 and 96. If we see less than 95, we need to really ask why, because that's considered hypoxic. So do we have really low respiratory rate? Is our ISO too high? Do we not have great contact? Our contact should be typically our lip, our tongue. We can do ears and we can do like a prepuce or a toes, but we want to make sure we have good contact wherever we connect it. Also, is our patient moving too much? Are they tremoring? Are they shivering? Are they too light? Are they seizing? But if we are still really still and we have good contact, maybe there's poor perfusion occurring. Is our patient hyperthermic? Are we dealing with a shock case? Are they having vasoconstriction? We can also see patients who are anemic who we are seeing this less than 95. Also, skin pigmentation can really affect it. So if we do have like a Doberman or a dark black shepherd, like a black one or a lab, we want to make sure we're on that pink skin. And so our tongue would be more ideal in that scenario. So when we talk about our perfusion, so this is how we also can see our CRT, our capillary refill time. So this is how we check our mucous membranes. So are they pink, which is normal, or are they pale, which can tend they're anemic? This is telling us we have some poor perfusion. Are they blue because they're cyanotic? They're red because they toxinemia or they're hypothermic. And of course, yellow, icteric. Are we seeing some issues with our kidney disease? Also brown for toxicity. So we use that CRT to check a lot of things too with our perfusion. And so our gums and our CRT, they should be separate checks because they're not indicating of the same thing. So our color is going to tell us a lot, and then our response time, which, is it less than 2 seconds or less than 3 seconds? Is it prolonged? Are we hydrated? Are we dealing with a shock case? Is this patient a cardiac case? Because if they are in heart failure, that's going to really determine our fluid protocol. So knowing these parameters is going to be very key. Our blood pressure, which again, I kind of talked about how my first clinic I ever worked at, we didn't do this type of monitoring, but it's going to be so key on how to give our patient a smooth surgery and also a smooth recovery. So when we're checking this, we are using a couple different options. We can use a Doppler with a sphygmometer, which is the handheld, or we can use the oscillometric, which that is like your Bionet or Vet check. Basically, that machine that displays a lot of these vitals already, like ECG, capnograph, and our blood pressure. So when we talk about our blood pressure, we have our systolic. So this is the contractions of the ventricles in the heart, and we want to see anywhere between 90 and 160. And then we also have our diastolic measurement, which is when the heart is resting. So that's anywhere between 50 and 90. And then we have our MAP, which is our average, which we want to see anywhere between 70 and 90. When we are achieving our systolic blood pressure as just a human in the practice, we are usually using a Doppler and a sphygmometer. So that's how we get our systolic measurement. When we're dealing with an oscillometric machine, this is where it can give us our systolic, our diastolic, and our MAP. If you work in ER or able to have gold standard, you can do a direct arterial blood pressure, but that's a bit more invasive, whereas the other two are considered non-invasive. But gold standard, which is going to give us the most accurate, is going to be our direct atrial blood pressure. So if we start to see low readings, that's what we call hypotension. And so that's where we start to see poor perfusion to vital organs. And this could be because our patient is way too deep on anesthesia. What drugs did we give that is this a side effect of? The patient could already have been in shock, or they are a heart disease case, or they're hemorrhaging somewhere. So this might be seen in like a hit by car surgery, like a dog that's been hit by a car and then the doctor is trying to fix whatever happened. We also have our hypertension. So that could be because it's pre-existing. So typically renal disease or cardiomyopathy or hypoadrenocorticism in our dogs, but also hypothyroid in cats can trigger hypertension. It can be cardiogenic, it just depends. But this is going to typically use medication prior, but we can give opioids to help reduce this if we're intra-op. But typically, these guys are already pre-diagnosed and they should already be medically managed prior to anesthesia. So our cats will be on something called amlodipine, and our dogs will be on something called benaziril. Typically, in my experiences in anesthesia, I always see the number go down. I don't see the number go up and stay up for a long time. So typically we can start seeing higher blood pressures if they're again being painful. Are they starting to be tachycardic? How do we intervene with those types of things? If we do have patients who are hypotensive, the first goal is to turn them down on gas. If they continue to be hypotensive after 5-10 minutes, this is where you can do a fluid bolus. And so keep that in mind when you're in your surgery procedure. And typically these fluid boluses are calculated specifically. So every clinic has a different type of protocol on that, but they will do sometimes it will be weight dependent. So if it's like a smaller patient, they might get a bolus of 50 mils or like 35 mils if it's a puppy to see if that helps. We can also go into our surgery if we know our patient is smaller or younger and we do see a lot of hypotension effects on those patients, keep them warm. So I like to put socks on their feet, all 4 feet, and you can have your warmies and your water blanket, things like that to help prevent those situations. All right, guys. So that um, pretty much is the end there on that presentation. I know it's a lot when we were talking about our prepping for VTNE. So one thing I can encourage you is to definitely write it out kind of in a map and just make sure you are able to identify your different types of drugs. How do we give them, also knowing their scientific name and their generic name. Math will be involved in your anesthesia. So when you're taking your VTNE, they will definitely give you math problems in regards to drugs, but they do give you all the information you need on that. There are some more things we didn't really touch base on, so I really encourage you guys to again review your vital parameters, your eye position, what we consider our ASA, so our anesthetic safety for a patient, what class they are, making sure you understand how to also check how deep with eye position, jaw tone, response to pain, things like that. That's going to really help you. I, if you do guys have any questions on how to prep for this or about the short little presentation I gave, just definitely shoot me an email. That's going to be kmarriott@pmi.edu. So you guys should be familiar with that format. And we can always discuss things on that if you do have questions. So that's the end of my anesthesia. I will meet back with you guys to discuss um, our large animal. That'll be in a separate conversation. So again, if you guys have questions, just shoot me an email. Okay.